I'd like to thank the organizers for inviting me to speak today. Today's topic is thrombosis and hemostasis, focusing on abstracts presented at the ACSO and EHA meeting. I'm Wendy Lim. I'm a hematologist at McMaster University. My disclosures are shown in this slide. Today we have three objectives. The first is to discuss direct oral anticoagulant treatment for cancer-associated thrombosis in the real world. We will assess the association of venous thromboembolism with anti-cancer drugs, and finally review the phase 1 and phase 2 safety data for rilzabrutinib for relapse and refractory immune thrombocytopenia. We will discuss these abstracts in the Canadian context and perspective. So prior to 2003, treatment of venous thromboembolism in cancer patients largely consisted of vitamin K antagonists, particularly warfarin. And at that time, there really was no distinction made of different patient populations. So patients with cancer were treated in the same manner as patients who did not have cancer. In 2003, publication of the CLOT trial showed that low molecular weight heparin compared to warfarin was associated with decreased venous thromboembolism recurrence. Subsequent randomized open-label trials comparing other low molecular weight heparins, including tinzaparin and enoxaparin, found similar findings in that there was a decrease in venous thromboembolism, but there was no difference in mortality and no increase in major bleeding with the various low molecular weight heparins. But this set the standard of care, and low molecular weight heparins as a class became the recommended first-line treatment for venous thromboembolism in patients who had cancer, who had adequate renal function, and this was seen in all the major treatment guidelines. The low molecular weight heparin treatment was continued for a minimum of 6 months or while the cancer was present. But what we found was that compliance with low molecular weight heparin was somewhat variable, with some studies showing that at 6 months, only 37% of patients were still on therapy, compared to over 60% for those on oral vitamin K antagonists. Along came the direct oral anticoagulants, and in 2018, there was publication of the first trial using direct oral anticoagulants in patients with cancer, and this was the Hokusai VTE cancer, and then subsequently the SELECT-D trials. The Hokusai VTE cancer study is shown on the right, and this was a trial evaluating edoxaban for treatment of cancer-associated venous thrombosis. And subsequent trials, including the SELECT-D trial using rivaroxaban and the ATOM VTE and Caravaggio trials using apixaban, compared these direct oral anticoagulants with low molecular weight heparin and found that the direct oral anticoagulants were non-inferior to low molecular weight heparin for preventing VTE, but at a cost of increasing major bleeding, particularly in luminal GI cancers, and clinically relevant non-major bleeding in genital urinary cancers, and that was seen in the SELECT-D trial. In the apixaban trials, there was no increase in bleeding seen. So if we look at the first abstract that we'll discuss today. So this was an abstract presented or will be presented at the ASCO meeting. And this is the comparative effectiveness of direct oral anticoagulants and low molecular weight heparins for prevention of recurrent venous thromboembolism in cancer. So this is called the Canvas Pragmatic randomized trial. So to take a step back, what is a pragmatic randomized trial? So as you all know, randomized trials assess the safety and efficacy of various treatments, but these settings are somewhat controlled and may not represent the real world. So pragmatic trials try to take real world evidence and randomization to assess a treatment's effectiveness. That is, how that treatment actually works in a real world scenario where the population may be heterogeneous. Pragmatic trials often use pragmatic elements, be it being practical in its eligibility, in its endpoints or follow-up. And as a result, the results are more generalizable and perhaps more applicable in a routine practice setting. So as I outlined, previous randomized trials have demonstrated that direct oral anticoagulants are non-inferior to low molecular weight heparin for preventing recurrent VTE, but do have a higher risk of bleeding. And so the balance between the benefits of VTE recurrence and perhaps the burden of bleeding is less clear. So this trial compared recurrent venous thromboembolism, bleeding, and death in cancer patients following initial venous thromboembolism and was treated with either a direct oral anticoagulant or low molecular weight heparin. So this was a non-inferiority trial, and they had two cohorts, a randomized and a preference cohort. And they enrolled patients starting from December of 2016 to April of 2020. So in the randomized cohort, they had 671 patients randomized and followed for 6 months. 140 patients actually declined randomization and actually chose what they would like to be anticoagulated with. And this formed the preference cohort. They were similarly followed for 6 months. For those who were in the randomized cohort, they were randomized in a 1-to-1 fashion to receive either a DOAC or low molecular weight heparin, and the physician or patient could choose whichever one they wanted at standard dosing. If they were assigned to the low molecular weight heparin, the protocol allowed a transition to warfarin. This was a US-based study, and they enrolled patients with solid tumors, but also various hematologic cancers, including lymphoma, myeloma, CLL, and they had to have symptomatic or radiographically detected venous thromboembolism within 30 days of being enrolled in the trial. The primary outcome was recurrent venous thromboembolism, and really they assessed this by establishing the non-inferiority of anticoagulation with a direct oral anticoagulant, which they defined by the upper limit of the two-sided 90% confidence interval for the difference in the event rate at 6 months, and they set it at less than 3%. So what you can see here is that for recurrent venous thromboembolism, there was no significant difference. Similarly with major bleeding and mortality in the randomized cohort. They had similar findings in the preference cohort, where they observed a higher rate of recurrent VTE with the direct oral anticoagulant, interestingly, also with higher major bleeding. But when they combined the two cohorts, the randomized and the preference cohorts, you can see that this was very similar to what we saw in the randomized trials, where the use of a direct oral anticoagulant resulted in a non-inferior risk of recurrent venous thromboembolism, no difference in the rate of bleeding, and no difference in the rate of death in the randomized patients. So the same trial also has a second abstract at ACSO, where they discuss the patient-reported benefits and burdens of the direct oral anticoagulants and low molecular weight heparins. So as we've already outlined, this was a trial that was a non-inferiority trial with both the randomized and preference cohorts. But importantly, for this particular analysis, they looked at secondary endpoints, including health-related quality of life and treatment satisfaction. They assessed quality of life at baseline at 3 and 6 months using the SF-12 survey. And then they reported treatment satisfaction at 3 and 6 months using the anti-clot treatment scale, which includes a burden as well as a benefit scale. What the authors found in this particular abstract was that the quality of life and the patient's perceptions of treatment benefits really did not differ between those patients who received direct oral anticoagulants or low molecular weight heparin. However, the patients on the direct oral anticoagulants reported a lower treatment burden compared to those who were assigned the low molecular weight heparin. So the authors concluded that in patients who were receiving a direct oral anticoagulant compared to low molecular weight heparin for treatment of cancer-associated thrombosis really did not notice a difference in their quality of life. But what they reported was a higher patient-reported satisfaction, and really that largely came from a decreased perception of burden of treatment associated with low molecular weight heparin. We'll turn to the last abstract that I'll discuss today, presented at ACSO. And this is an abstract looking at anti-cancer drugs that are associated with venous thromboembolism and analysis of the World Health Organization pharmacovigilance database. So what these authors did was they looked at the association between these various anti-cancer drugs and thrombosis, and they used VIGIBASE, which is the WHO global database of individual case safety reports. This is the largest database of its kind in the world, and it was started back in 1968, and it has more than 20 million reports of various adverse effects of medicines, and these are submitted by member countries of the WHO Program for International Drug Monitoring. They performed a disproportionality analysis that reported odds ratios to determine the association between 206 FDA or EMA labeled anti-cancer drugs and the association with venous thromboembolism, which they defined as either DVT and or pulmonary embolism. These reported odds ratios were then adjusted based on population characteristics, including cancer risk of venous thromboembolism and primary tumor site, and they used the Corona classification. So they found over 50,000 venous thromboembolism cases were associated with at least one anti-cancer drug. But what they found was that 13 anti-cancer drugs were associated with a higher reporting of venous thromboembolism, and they found two new associations that they had not previously confirmed. So the identified anti-cancer drugs, the new ones that they identified was a drug for prostate cancer and one for breast and endometrial cancer. And not surprisingly, actually, they also found that immunomodulatory agents such as lenalidomide, thalidomide, and then they also found bevacizumab were associated with a higher risk of venous thromboembolism. And these drug-associated thrombotic events generally occurred during the first 6 months after the drug was initiated, leading these authors to conclude that recognition of certain anti-cancer treatments can cause VTE, and they felt that this can raise awareness and lead to perhaps earlier diagnosis and treatment, and also considered that perhaps anti-cancer drugs should be evaluated when one is considering what an individual's venous thromboembolism risk might be. We're going to turn our attention to the EHA conference and hemostasis. And this is an abstract that presents the phase 1 and phase 2 safety and efficacy results of the oral Bruton tyrosine kinase inhibitor rilzabrutinib. And this is for patients with relapsed or refractory immune thrombocytopenia, or ITP. So as we all know, ITP is characterized by an immune-mediated platelet destruction as well as impaired platelet production. And as a result, patients have low platelets or thrombocytopenia. Rilzabrutinib is an oral, reversible covalent inhibitor of Bruton tyrosine kinase. And BTK is expressed on platelets. And it's thought to its mechanism in ITP is thought to decrease the platelet destruction by inhibiting macrophage phagocytosis. So in fact, this data was presented in the phase 1, phase 2 data was presented at the American Society of Hematology meeting this past December. And at that time, they presented the data on 32 chronic ITP patients. So very briefly, these are patients with a median age of 50 who've had ITP for about 7 years and haven't responded to a median of 6 prior therapies. So really refractory patients. Half of the patients achieved a platelet count of over 30,000 in the first week. And so that's often an important threshold because that's where we might initiate treatment. And over 50,000 platelet count was obtained in 42% of patients. And the phase 3 study is ongoing. So as a reminder, there are multiple different mechanisms for for ITP, either destruction or decreased production, but BTK inhibitors are thought to act at the macrophage level and decrease platelet destruction at this particular level. So this was an open label adaptive phase 1/2 study that evaluated the safety and efficacy of rilzabrutinib in patients with relapsed or refractory ITP, and this could be either primary or secondary ITP. These were patients who previously responded to one or more prior ITP therapies and really had no other treatment options. If they had 2 platelet counts less than that 30,000 threshold, they received rilzabrutinib, and they studied various doses of 200, 400, 300 twice a day for a total of 600, and 400 twice a day for a total of 800 milligrams daily, and dose escalations were allowed. They also allowed patients to receive treatments with steroids, as well as TPO agonists if needed. And their primary endpoint was 2 or more consecutive platelet counts over 50,000 and increased from 20,000 from baseline and did not need rescue medication. So this particular analysis included 31 patients. As mentioned in the primary study, the characteristics were pretty much the same. 26% had had a prior splenectomy. The median platelet count was 13 at study entry. 32% of them just received rilzabrutinib on its own, and 68% also received an additional ITP medication. And what they found was that the treatment emergent adverse events were all only grade 1 to 2 and were reported in 35% of the patients. Largely, the adverse events were nausea, diarrhea, abdominal distension, and fatigue. But importantly, there was no dose-limiting toxicity seen, and there was no significant change seen in the ITP BAT bleeding scale. So what these authors concluded was that the rilzabrutinib was active at all the dose levels studied, and it was well tolerated. The dose escalation portion showed a rapid, durable clinical activity and tolerable safety, and these were in patients who had been refractory to multiple treatments and really had no other options. So they're now expanding enrollment at the optimal rilzabrutinib dose of 400 milligrams twice a day, and they're going to use that as the starting dose to characterize the magnitude and durability of the clinical benefit. From a Canadian perspective, thinking about these abstracts, the use of direct oral anticoagulants for both treatment and prevention of cancer-associated thrombosis has been increasing, and this has been since the publication of the Hokusai VTE cancer, the SELECT-D and the Caravaggio studies, and those were the treatment trials evaluating direct oral anticoagulants, and more recently with the AVERT and Cassini trials, which were the trials evaluating DOACs for prophylaxis. In Ontario, the main limitation for using direct oral anticoagulants really is reimbursement. We have a limited use code available for treatment, but that only goes up to 6 months. And unfortunately, we don't have direct oral anticoagulants listed among the Exceptional Access Program medications. So patients can be treated for upwards of 6 months, but there's no additional coverage. So really, use for treatment beyond 6 months or for prevention really is going to be based on patient healthcare provider preferences as well as the patient's drug coverage. We recognize that immunomodulatory agents such as lenalidomide or thalidomide is associated with venous thromboembolism. It has resulted in various prophylactic strategies. So many centers, including at McMaster University, for patients without a history of thrombosis will utilize aspirin and some consideration of antithrombotic agents in patients who have a history of thrombosis. And finally, treatment for immune thrombocytopenia continues to evolve. In Canada, we have standard therapies including steroids, IVIG, splenectomy, TPO agonists, and rituximab are used in select patients, but certainly this is an area where other treatment options are needed, so the data on rilzabrutinib are very interesting. So in summary, the DOACs have been shown in clinical trials to be effective for treatment as well as prevention of cancer-associated thrombosis. And the abstract shown that use in the real world for cancer-associated thrombosis demonstrates patient acceptability with higher patient-reported satisfaction, particularly related to a decreased perception of burden with no difference in quality of life. We know that certain anti-cancer drugs are associated with thrombosis, particularly immunomodulatory agents. And finally, rilzabrutinib continues to be studied as a potential treatment option for relapse and refractory ITP. Thank you very much for your attention.